Okay, hello and welcome. Let's get started. Thank you for attending this webinar, Real World Crisis Collaboration. Today, we are excited to host well-known healthcare leaders as they discuss their path to resource sharing and coordination to weather the many challenges created by COVID-19. I'm Lauren Duff. I'm a current student in the Health Administration MBA program at the CU Denver Business School and the co-president of the Health Administration Student Organization. This presentation is produced by the Health Administration Student Organization at CU Denver. We represent the interests of students in the graduate health administration programs and regularly provide networking and professional development opportunities within the program. The Health Administration Student Organization really thanks Centura Health and St. Joseph's Health for their willingness to share their insights with the healthcare community today. We're looking forward to engaging with our attendees' questions today, and we'll respond to as many as we can. If you have any questions for our speakers, you can submit them in the Q&A area on the right side of your screen. You should see a purple button that will allow you to do that. And then one more note before we introduce our speakers. This webinar will be available for access for those who can't attend at the moment. We'll be recording this session and posting it to our LinkedIn and Facebook pages. And we'll also be sending it to all registrants after the webinar is complete. So joining us today are three healthcare leaders. Dr. Rulon Stacey is going to be moderating this event and kicking us off. He's an internationally known speaker and leader in the healthcare industry. He has served as CEO of several healthcare systems, chair of the American College of Healthcare Executives, and chair of the Malcolm Baldrige National Quality Award Board of Overseers. He's the current chair of the CEO Circle of the International Hospital Federation. He's received a number of awards for his efforts to improve the quality of the healthcare industry and was twice named as Modern Healthcare as one of the 100 most influential people in healthcare. Dr. Stacey is currently the program director of the graduate programs in health administration at CU Denver and a part-time partner for the healthcare strategy business unit at Guidehouse. He provides expertise in the areas of organizational transformation, strategy development, and performance leadership. He has a BS in economics and an MHA from Brigham Young University, as well as a PhD in public administration from CU Denver. Kevin Slavin is President and Chief Executive Officer at St. Joseph's Health, an integrated multi-hospital major academic healthcare system based in Paterson, New Jersey. He's responsible for the overall clinical, academic, and operational functions of nonprofit St. Joseph's Health, which encompasses St. Joseph's University Medical Center, including St. Joseph's Children's Hospital in Paterson, New Jersey, St. Joseph's Wayne Medical Center in Wayne, New Jersey, St. Joseph's Healthcare and Rehab Center in Cedar Grove, New Jersey, and outpatient sites across North New Jersey. Mr. Slavin received his master's degree in health administration at the University of Colorado's Graduate School of Business with an emphasis in financial management. He holds a bachelor's degree in industrial engineering from Rutgers University in New Jersey. Mr. Slavin is a trustee and chair of the New Jersey Hospital Association, a member of the American College of Healthcare Executives, a trustee and immediate past chairman of the Hospital Alliance of New Jersey, and has held a variety of legislative appointments to healthcare boards, commissions, and task forces. Peter Banko is president and CEO of Centura Health, a $4 billion integrated healthcare system sponsored by Advent Health based in Altamonte Springs, Florida, and Common Spirit Health based in Chicago, Illinois. Mr. Banko brings faith and business together, uprooting traditional ways of thinking and working to cultivate real compassion into purpose and creative ideas into innovative solutions. He's firmly committed to teaching, supporting, and lifting those around him to help them fully live their missions and change the world. Day in and day out, he inspires the organization's connected ecosystem of 21,000 caregivers across Colorado and Western Kansas, who together are on a mission to redefine health, one whole human and one health neighborhood at a time. Mr. Banko is a graduate of the University of Notre Dame and Cornell University Sloan Program in Health Administration. He's a fellow of the American College of Healthcare Executives and the AHA Health Forum Creating Healthier Communities program. So with that, thank you all for joining us today. I'm now going to turn it over to Dr. Stacey, who will be moderating this discussion.
Lauren, thank you very much for your time and your preparation. I want to recognize Lauren Duff and Anthony Pfaff, who are the co-presidents of the Health Administration, the Health Administration Student Organization at University of Colorado at Denver. They have really stepped in and helped us out. Kevin and Peter, thank you both for taking the time to talk to us today. I will tell you that shortly after taking this job, Kevin reached out to me and told me that he was an alum of the program and has expressed the willingness to talk to the students. Peter has been a supporter of the program for years. In fact, we currently, as we speak, have a Centura scholarship at the program, and we appreciate that support. And when Kevin told me they were going to be together, we thought, even if we can't get the class together, let's do what we can to take advantage of this. So thank you both for being here, and thank you to Lauren and Anthony and the program advisor, Lindsay Borelgi, who is also with us on the phone today. So as we get started, Kevin, I'm going to start with you and ask you to give us a little bit of background. I noticed on your LinkedIn page today that you were celebrating the 1,000th COVID patient in your organization. That is a very big number. Tell us a little bit about St. Joseph's and about what your life was like 1,000 patients ago.
Yeah, great. Thank you, Rulon. Thanks for having me here. It's a real privilege to do that, particularly with my good friend and Peter Banko. I won't go over my background. You did a very nice job. I'll just say I'm uniquely qualified to lead during this time through the great education I got in the program back when. I worked with Peter in the 1990s in New Jersey. We did a lot of positive things together in the health system there, and then we always stayed together as friends and mentors. And over this past 2 months, we've been talking about different experiences, obviously New Jersey being ahead and at the epicenter. I was curious what was happening in Colorado, learn from each other. And then at a particular point, we were really in need of relief for our staff from burnout and all kinds of things. And Peter was gracious enough to supply not just St. Joseph's, but 2 other Catholic hospitals with nurses to come and give relief. And it was a huge boost of morale. We had just passed the peak, and to have them come, we call them angels from Colorado, and you'll see a slide, just boosted the morale of all those organizations tremendously. I assume the chair of our hospital association, so I give you that perspective. And in January, in my opening address, I made a prediction. I said to the industry in New Jersey that I'm quite sure there's going to be something that comes our way that's going to be huge and monumental that we'll have to adjust to, that we don't know about as I'm standing here today. So, you know, I was clairvoyant. Right?
Did you said that in January?
In January, yes.
So we've been looking for the person who's responsible for this.
Yeah, I guess so, right?
Okay.
What you meant, though.
No. So go to the next slide there, 153. Just a little bit on our background. I think the most important thing I want to get across is, you know, we're sponsored by the Sisters of Charity St. Elizabeth. That's an order in New Jersey. It's still very vibrant. They came to this industrial city, the first industrial city that Alexander Hamilton designed, to serve the poor, vulnerable, and underserved. And we're still doing that 153 years later. We're a big safety net organization. If you go to the next slide, our sisters cared for this community through many different pandemics. They're known in the city of Paterson for when it was under quarantine during 1918, and people were dying, including children. They rode through the city in a horse-drawn carriage to take the dead from the houses and bury them. So that started that deep connection that we've all maintained through our sisters. I mentioned the system. We serve a very vulnerable population in Paterson, 3rd largest city, very diverse, and that's a key theme that I'll get across here. This COVID-19 has hit vulnerable communities a lot harder. Our community is split in African American, Latino, and we also have the 2nd largest concentration of Arab Americans in the country, second to Dearborn, Michigan. So very diverse, but I'll talk about that a little bit later. So let me move to New Jersey. We'll move up a couple slides to the players. Back up a little bit. There you go. One of my themes is in healthcare, I've learned in my career, the relationships matter. That's what really drives a lot of success, the relationships you develop over the many years. I'll start at the bottom there. The central figure at the bottom there, Sister Marie DePazzi, was a great CEO in New Jersey that Peter and I both started under. She was a mentor to both of us.
She's the reason I got into this profession. Yeah.
That was at different times. We didn't know each other. We connected later in the 90s.
I would hear your name in the 80s, like, you got to go work for Kevin. You got to find Kevin.
Really?
I did. Yeah.
And then if you move up center, our current Commissioner of Health, Judy Persicilli, some of you may know, was for several years the CEO of Trinity, the national system. A critical care nurse by training, was a CEO in the state. She also worked at St. Peter's, knew Sister Marie DePazzi, knew Peter, knew myself. So
she gave me my first administrative job.
She did. New Jersey would not have been able to weather this storm as well as we've done without Judy uniquely in this position, being a nurse, a former CEO, bringing that perspective. To the right is Kathy Bennett. She's the president and CEO of our hospital association, who also is a former health commissioner in New Jersey under Chris Christie. You would think that might create a tense relationship. It's quite the opposite. The commissioner relies on Kathy because of her experience in state government, getting things done. We've been working very collaboratively. And then we have our governor, Phil Murphy, who's done a tremendous job. And we know this in our state. It's public. He made it public. Right before this hit New Jersey in early March, he was just recovering a week before that from major cancer surgery, and had just come back onto the job when this hit, and has done a fantastic job.
And his general counsel was my high school classmate and carpool person when we ran track together. So
we're all connected.
It's a small world.
Yeah. Next
so
one, just
before you go on there, Kevin, can I explore that for a bit, since this is ostensibly for the benefit of the students who are listening. I get questions a lot from students, and they ask me about creating a network, and it's not what you know, it's who you know. And I understand that, but it sounds like both of you have been developing your relationships with each other for a long time, but it's not just those, it's people that you get to know over your time, and your relationships have been developing. Do either of you want to comment on that?
Yeah. There are a lot of great people during the course of my career that took an interest in me, and I owe to where I sit today, and Kevin's one of those. But you meet people along the way, and you never want to burn bridges, and you start to develop a group of people that you rely on. So, CEO is a lonely job, right? You don't have any peers. There's no one in the organization you can talk to. So during this pandemic, there are probably a dozen people that I talk to or text with weekly. Kevin's one of them. And just to find out what's going on elsewhere, what are they thinking about that I'm not thinking about? So building that resource over the course of your career. And I always tell students, pick the person, it's easy when you're an MHA student to pick the job that has the great title or the pay, but pick a really good person to work for, because that's how your network's going to start to build. And Kevin was one of the first people I worked for after grad school.
I failed to say, too, I'll add to that Peter and I are disciples of the great Lee Kaiser.
Yeah.
Lee was still teaching in the program when I was there, and then we went through his Creating Healthy Communities leadership program. And I remember Lee one night doing a lecture for the students on career development, saying that 80% of the jobs are found through networking, or not through, not knowing the individual. So I can't overestimate it.
And a funny story about Lee is I started the job with Kevin, and I got a job description, and there was a line in there. I don't know if you remember, about community development group.
Oh, yes. Yeah.
And I went home to my wife. I was like, what the heck does that mean? And then Kevin introduced me to Lee, and now we work with Kevin Kaiser and Leanne Kaiser Carlson for our team development. So, yeah, I mean, I've known you for almost 30 years, and those relationships never go away. And while you don't talk to somebody, they prove valuable when you need them.
Well, I appreciate that diversion there, because I think that's helpful for students and other professionals who are listening. Kevin, I kind of got in the way of your telling me about your organization, so you can keep going. Sorry about that.
I'll zoom through the next ones and come back to questions. This next one, the state coordinating. This is the structure that the governor and the Judy Persichilli, the commissioner, put together, a task force. We have a daily command center group I'm a part of every day, 10 a.m. Saturday and Sunday. That's been going strong for 8 weeks. The commissioner has used a professional advisory committee, which allows her to take feedback from the industry, from stakeholders, and then when the governor does executive orders, that allows the attorney general to be able to legally say he can do that. There's been regional designations, leadership, a lot of collaboration, which I can talk about. Next slide talks about the areas of coordination. Our hospital association stepped in to coordinate for the state how PPE would be allocated. We set up a central data portal that everybody agreed to report their data. It started every morning at 10, then it moved to 10 o'clock at night so we could get real-time information. That's driven how the supply of ventilators and all kinds of other things, including morgue overcapacity, portable morgues, have been allocated out to the hospitals. And currently, we have just gotten a significant distribution of remdesivir, and it's following the same process. There's a group that comes together, clinical leaders, that decided how that should be distributed. So some great collaboration there. Analytics drove a lot of this early on. I'm not going to go over these. This is part of a deck that we look at every morning on the command center. The state engaged McKinsey to come in and do high-level analytics, and this has been so monumental to be able to see these things in real time and then comment and say, oh, we'd like to see this. And if you go to the next slide, I think this is the one. This is on lab testing. This evolved from something very basic, and people said, I'd like to see this, I'd like to see that. Overnight, McKinsey would just spin out a new analytic. A little funny story here, when this was finally finished, the young man who presented it was so proud of it, and somebody said, Daniel, do you think you could get one more thing on that slide for us? You know?
And we actually stole this from you early on. You shared this with us, and we were able to build our own analytics internally based on what you shared. So it was helpful for us to manage the process by the numbers rather than winging it.
So next is just highlights of the state. This was at our peak. The peak for the state, the northern part of the state where I'm in was the epicenter. The disease traveled down the state, went to the central part, and the southern part, you can see at this point, was still rising. That has just leveled off. North Jersey has gone down. The governor just decided yesterday, though, he's not going to open up by regions. He's going to wait until the entire state. You can see the St. Joseph's numbers. I think the next one is a good visual. That's our collective angels from Colorado at Newark Airport. It was fantastic. I know they were seen off by the Archbishop here, and they were greeted by two of the bishops there to bless them. And just a great, United had a number of people there to greet them. That's internally St. Joseph's census. Total is green, and you can see the blue is the COVID, where we peaked right after, they came right after that, which was monumental. And the big issue for us is the non-COVID patients not coming to the hospital. We're now really pushing hard publicly to tell people hospitals are always safe. They're safe now, and they will be safe because we have people staying home and unfortunately dying of heart attacks, stroke, ruptured appendix. Our paramedics have seen a quadrupling of pronouncements of death in the home since the beginning of March.
We have here too, and now our ICUs are full of people who have delayed care to the point where it's not good.
I know, we want to get them back. So that was as of Monday. You can see just high level numbers, tremendous amount of death. And I want to point to the next slide. This is the 8 employees of St. Joseph's Health who have all lost their life to COVID-19. Just yesterday, we finished calls to each of their families. Myself, the VP of Mission, and usually their manager or director joins me in those calls to express our sympathy. You can quickly scan and see that 6 of the 8 are people of color, and that has been a central theme in New Jersey. This has hit the vulnerable populations much harder. Certainly, many have underlying conditions. Social determinants of health now is being pointed to in a big way. and lots of interesting stories here. I'll just share one. The gentleman far right bottom guy was a long-term care nurse who actually worked 37 years in the organization before it was a long-term care organization. The gentleman to the left of him, Brian, became a nurse at St. Joseph's 6 months ago at the age of 60. He was an EMT in New York and was on served during 9/11, had a tattoo on his arm that said, "I cheated death, 9/11," and wanted to become a nurse because at 60 because he wanted to see the other side of the door, he said. He was always dropping them off at the door, leaving, and he did. He accomplished his goal. Unfortunately, he lost his battle just a week ago. So that's a central theme. I'm going to come back to this one if we have time, but I'm going to ask the group. Here's a question for you. Top left, you may notice if you're NBA fans, that's Danilo Gallinari, former Denver Nugget, myself, my wife, and my cousin. And bottom right is one of our prophets, Bruce Springsteen. So we'll come back to it if we have time. What does Gallo and Bruce Springsteen have in common? And I'll answer that question later.
Is that New Jersey trivia?
New Jersey trade will be, yeah.
Wait, are you going to leave us hanging on that?
Yeah,
That's
I'll
cool.
come back to it. I want to give Peter his time here. Just a few things on some tremendous innovation. We have a different approach in innovation at St. Joseph's. We were funded by a grant from a state foundation to teach innovation techniques learned from the Kaiser Foundation, design thinking, rapid piloting, different things like that. And we want to spread it out to the organization. We're not doing the Shark Tank approach. So we've begun that process, but now just put it in real time. So we found our lab folks found out that through our vendor, we could repurpose some existing lab equipment through Becton Dickinson and change our turnaround time from 7 days to 2 hours, which completely lowered our burn rate of PPE and cohorting of patients. Then we got so good at that, we were backlogged because we would run out of reagents. So our microbiology manager, who was home quarantined, researched and found a way to make that ourselves. So we are now making our own reagent in the laboratory. And the engineering team was a part of this, repurposing space to negative pressure rooms. Really important to visualize these patients. So when we change entire units to negative pressure, they would take a door off when a patient left the room, take it down to the maintenance shop, cut a hole in it, put plexiglass, and bring it back up by the time the room was ready to be inhabited by the next patient. So I'll just close with some of my key learnings. Again, relationships and trust, the underpinnings, the vulnerable populations I mentioned, continuous focus on talent acquisition and development. I early on had to develop, I was working on succession planning with my board, hadn't had that done, but I stopped and developed an immediate succession plan that said what would happen if I were to be sidelined, because we did have a number of our leaders that were exposed, and I can talk about that as part of the story. That's part of the piece of the puzzle. So 2/3 of our emergency preparedness team, many of our nursing leaders, and half of our infection control team were quarantined during the first 2 weeks of this crisis. So you look down the bench and you have to say, okay, next one up, let's do it. So a real focus on that. Certainly this has been the biggest disruptor in healthcare I've seen and many have seen. We have seen a huge increase in telemedicine. It probably advanced in our state and our market, telemedicine 2 to 3 years, and it's not going to go back. I'm one who now does telemedicine and I like it. I've talked about the rapid innovative solutions, the need for quick decision making, and we like that now. So we're not going to go back to the way we made decisions before. We're going to keep some of the new things we put in place. Some solutions that we thought would be temporary have actually had better outcomes, quality and cost, and patient satisfaction. So we're going to keep those. I mentioned the analytics and just the need to continually communicate to keep everyone up to speed. We do a lot of employee town calls, physicians. That's pretty much takes up my week, is constant communication, visibility, and the need in our case to have crisis communications. And that's another piece to that quiz that I'll hopefully get to. So now I'll turn it over to Peter.
Peter, tell us your side of all this and how this happened.
Yeah, I mean, a lot of key themes, but not what New Jersey experienced by any means, either in Colorado, although we're seeing a spike in Western Kansas. So Centura, our first ministries were founded in the 1880s in Pueblo and Durango. So we've got a storied history, and like Kevin, we found stories throughout this around, our hospital in Durango within a year of opening was shut down for 5 months because of smallpox, and the sisters didn't give up and they reopened. And we have some stories from our Pueblo community around the 1918 influenza pandemic. I would say the things that we learned about 1918 is public health had a more primary role in our communities then. Exactly. And we've spent at least the last decade, maybe two, underfunding public health in our state and in the country. And some of the communities have looked to us to do public health, and we just weren't built for it. And I think that's something that's going to change, is we're going to have to get back to classic public health and healthcare. And there were a lot of community organizations in 1918 that really stepped up that we're missing now. Our history is also, we're both an Adventist and Catholic ministry. So one of our first hospitals was in Boulder. It was actually founded by Dr. Kellogg, like the cornflakes, Dr. Kellogg. So it was about health and wellness. And our board meeting yesterday, our board really said, hey, how do we get back to what we were originally supposed to do? It was health and wellness. But understanding, as much as we've talked about since you and I have been in the industry about acute care going away, it's become more important now than ever. So we have 17 hospitals, 14 affiliates. If you see the orange helicopters around Colorado, that's Flight for Life. It was actually the first hospital-based helicopter program in the United States. Aligned physicians and all that other good stuff. We also, what's been interesting for us is we also have global health initiatives. So we have active ministries in Cuba, Haiti, Nepal, Peru, Rwanda, and Tanzania. And that really, as we talk about going to New Jersey, it was just another part of our mission. And Peru's being hit hard right now. Our hospital there is literally shut down. The physicians and nurses, our head physician had to be shipped to Lima, and he's on life support. So other parts of the world have been impacted as well, the whole world. So just Colorado and Kansas. So the first presumptive patient was presented to our hospital in Frisco, St. Anthony Summit on Wednesday, March 4th. I was sitting in this exact same seat, and my cell phone was in my office next door, and someone ran in here and said, the governor's looking for you. And it was at the time the public option was heated here, and I'm like, I don't want to talk to him about that. And they said, no, it's more important. And he said, we have our first patient in Colorado, and that was news to me. So did the press conference. I think what we found here were the first patients that first patient was a resident of California that had been in Rome. And so the first patients that we saw really all involved foreign travel, either, not to China, largely to Italy, and then cruise ships. And then, as Kevin said, it has changed since then. So in less than 2 weeks, all of our elective outpatient emergency department volume that is profitable disappeared overnight. I've never seen anything like it. So we lost $25 million in revenue, like with a snap of a finger, which is about a third of our revenue, and equivalent to about $1.3 billion a year. And so as you looking to manage this, as I've said in other forums, when your volume disappears and your revenue disappears and there's not enough costs you can address to take care of it, then the financials then take a back seat, and it really then becomes about taking care of your people. The governor in Polis issued the first stay-at-home order on Thursday, March 26th, but the big things, as much as people complain about the stay-at-home, shutting down the ski resorts, shutting down the schools before this has really had an impact. So our highest census day was March 28th with only 269 patients. Our highest vent day was April 11th with 120 patients, and to date we've only had 69 deaths in the system. We now today have it's spiked a little bit the last couple of days, so we have a little over 100 patients across our 17 hospitals. Amongst our associates, we've tested more than 600 of our 21,000 associates. We've now, I think as of today, have 65 positives, and we've not had one hospitalization amongst our associate base. So some of our communities reopened 2.5 weeks ago, others May 8th, and larger scale reopening plan for May 15th. And then I'll just cover the last slide, kind of lessons learned. So our first priority from day one has always been about our caregivers, and it came from our philosophy of we need to be there when our communities need us most. So we took some steps for our associates around keeping them whole. So in terms of taking paid time off, providing some compensation as stopgap measures. For our employed physicians, we provide some guarantees for 2 months and then a lesser guarantee for 2 more months. In hindsight, this is the one area I would have done more. From the perspective, our board talked a lot about this yesterday. Sitting here in March forecasting it, we thought we would be overrun like New Jersey in mid-April, and we thought that would continue into June. It just hasn't happened because the stay-at-home measures, from my perspective, have worked. So we actually spent time earlier today. We're going to go back and recalibrate with our associates and make up for some of that paid time off and the compensation losses that they've had in the next 30 days. We provided free meals every day. We found our associates couldn't get to the grocery store with reduced hours, and by the time they got there, there was no toilet paper. Not that there would have been if they were there any earlier, which is kind of bizarre. But so we actually worked with Cisco, our food service, and we provided, people could deliver their order in the morning, and we'd have their groceries waiting for them when they went home at cost. We partnered with the state on childcare assistance because the schools were closed. So we stood up childcare with the Buell Foundation for all first responders and healthcare workers in the state. Colorado Christian College provided dormitory housing for people afraid to go home. You probably experienced people didn't want to bring it home to their families. Yep. And then just the ongoing emotional support. We've the PTSD and other, it's sparked issues with our associates and physicians that we've had to stay on top of. Your point, Kevin, about evidence-based guidelines, I think you said to me on a call, maybe there are things we shouldn't go back to. I think we found that. So the use of PPE, one set for every person, we're gonna probably have to do some studies to see, well, that was a lot of money and it probably didn't protect people any better than we're protecting them today. I think from a clinical perspective, our doctors just within the last few weeks the practice has always been when someone's O2 sats get down to a certain level, they intubate them. I think we're finding with this disease, delaying intubation, putting them in a prone position was better off. So our physicians are questioning the things we've done, our nursing from an evidence-based practice, but I think from a management perspective, we've got to question that. The virus I found is very community specific. So we had 4 of our hospitals, Littleton, Parker, St. Anthony and Lakewood, and St. Anthony North and Thornton, that were the hardest hit. We have other hospitals that had less than 5 cases still today total. St. Catherine in Kansas is now seeing a major rise. Your point about race and ethnicity, socioeconomic status, high density housing, we have less of that than you do. Right. But a lot of our community can't work via Zoom and have to show up every day, and so there's exposure, and so that tends to be people with lower socioeconomic means. So I think that's something we need to look at as well. Other parts of our business disappeared. So it was hard for our caregivers to understand that the ICU was literally overflowing at the facility and the imaging and the ED were empty. Mm-hmm. So how come I'm being called off and then you're supplying extra resources elsewhere? I would say this virus has a special knack for exposing weaknesses. So It required, if you weren't a team player in all this, you got left behind. If you couldn't collaborate, like you said, externally, internally, and so some of our leaders who were superstars fell flat on their face during this, and others that were struggling found like a new energy.
Absolutely.
I'm thinking of one of my execs in particular, like he has been a totally different person for the last 8 weeks, from a leadership perspective, and it's been nice to watch. It tests your operating discipline, like you said, your ability to manage by the numbers, not by the seat of the pants and analytics and metrics. The breakdowns in the supply chain across the board, I think we're going to have to rethink how we do supply chain and not rely on other countries. And then I talked about the decades of underinvestment in public health and the ability to public contact trace and test. Testing has been a whole nother saga that we can get into with Q&A. So that's where we've been, a different story, but we had an ability to help you. That's why we did it. Rulon, you asked earlier, why'd you do it? Well, it's core to who we've been. And when a friend calls you, Kevin and I worked for a boss, and you'll remember we would ride back with him, and he would promise stuff in a meeting, and that he couldn't deliver.
He knew he couldn't deliver.
And we would sit there, like, Joe, like, we can't do that. He's like, that's not my problem. I'm the CEO. You need to figure out how to do it. So Kevin and I would then scramble to figure out actually how to make it happen. So when I got the call, I was like, yeah, we're going to do this. And I said to the team, we're going to do this. And they're like, we can't do it. I said, that's not what I want to hear. You're going to figure out how to make it happen. So literally in less than a week, we had people on the ground in New Jersey.
Yeah, absolutely. Yeah.
So tell us.
King has done a great job there. She's a real star.
So tell us how that happened. Tell us the process of, Kevin, you realizing I got to have help, and Peter, you thinking, well, I can help. What were the step-by-steps process to make that happen, to get nurses and others from Colorado, identify a need in New Jersey, find them in Colorado, and get them to New Jersey?
Well, one of the things that was happening first with PPE and then with staffing in New Jersey was the price gougers. You know, us being, pricing going up 4 and 5 times what it was pre-COVID. That certainly was PPE. And then it started with the staffing agencies. And we were just being, overwhelmed, and we just had to get nurses. We were challenged by the commissioners to double our capacity of ICU and hospital beds. We made it happen on the physical side, but we needed the nurses predominantly. There was a call to action of retired nurses in the state. Through a core that they had developed, but they found that many just declined because of their age. They were in the vulnerable category. And I remember talking to the Attorney General one day, or bringing it up at a meeting, that these price gougers should, I think our governor, I know he said his quote was, there's a special place in hell for price gougers during COVID-19. The Attorney General said, give me an example and I'll try to prosecute them, which we never got to, but at least the message was sent. And I was relaying that to Peter, and then you had some excess.
We had some communities that weren't hit that hard, Pueblo, Colorado Springs in particular. And we had parts of our system we were calling off emergency department staff. And I was getting a lot of complaints about, hey, I'm having trouble getting my hours. So Kevin called me and I said, hey, I think we could put it together. We put a call out. I think he originally said 25. We ended up sending 34. We had more interested. The stories of the staff were, my spouse lost their job, or one was coming back, she had a little baby and I was wondering why she was going. She's like, I came back from maternity leave, my husband's out of work and I need work. But others just felt the call. So when a nurse somewhere else says I need help, they were willing to go. So we had more people interested, and it all kind of came together. United flew them there for free. The CEO of United gave them a Zoom send off here at DIA.
No, wait. Your nurses flew to New Jersey courtesy of United Airlines?
Yes.
Yeah, absolutely free.
And back.
Wow.
And back.
Good for them.
Amy King, our chief people officer, chief HR exec, was sent with them, so they had someone to connect with while we were there. But she literally worked with your HR people and the others at the other 2 hospitals. They put it together. There were insurance. Kevin and I would text and all our folks would find a reason not to do this. And I kept saying, we're sending people. The governor said on Friday, we're sending people, we're sending people. So we worked through insurance and compensation, and all that fell into place like miraculously.
Yeah.
But it, I can't take any credit. It was Amy King and our team. Really.
That's an interesting discussion, Peter, because the first thing you've got to do to work through something like this is want to work through it. The second thing is there's a lot of boxes to check, and insurance, and it's just one of those things. So yeah, no, that is wonderful. Lauren, have you had any questions come through?
So we do have a question that came in from Deb, and I can go ahead and pose that. It is directed to both of our guests today. So she said, "Hi, Kevin and Peter. What mode of communication did you find was most effective for the clinicians in communicating with family members during this restricted visitation period? Was it effective for the staff to initiate Zoom sessions with the families, text message updates, or scheduling telephone communication on a regular basis?"
That's a great question. I don't know if there's any one that would work better than the other. I'd say it was all the above, but that was one of the most difficult things for our workforce, particularly the clinicians, to have so many patients pass without loved ones in the room with them, obviously. So they would do what you just said, Zoom, phone calls, whatever they could, but I'm going to say many cases, they could not make that connection. The patients would go so fast, deteriorate so fast, that they would have to be the ones with them during the time of their passing. And it was just, I remember walking up on one of the units where one had just passed, and the whole staff was just broken down and difficult. So we are going to be looking at trying to help them recover through some resiliency training, but it was just really difficult. And also, early on, I put a stop to any clinician having to transport a deceased patient to the morgue, because there's a story behind that, but that was a double hit for them, so.
Yeah, I took a lot of criticism here. We were the last system to stop allowing visitors. So really up until probably April 7th, we allowed one visitor, and I came at it I got a lot of pushback from my team internally. I said, no one's going to come into this world or leave this world without a family member with them. And so we cut it off April 7th, thinking we were going to see a surge. We opened it up probably about 2-3 weeks ago. So a lot of my colleagues in Colorado and Kansas weren't happy, but we allowed visitors. So during the 3 weeks or so we didn't, same thing, Zoom, telephone calls. The other reason why we were so late to go to it, our clinicians said, we appreciate the one visitor while it can create issues around PPE and other things. We didn't want to have to be on the phone all the time, 5 times a day with the family. It allowed them to stay focused in on the care, and then it allowed the family members to be there. So we had the luxury of taking a different position than others. It wasn't the most popular, but it served us well.
A couple of the university faculty and I just put an op-ed into Health Leaders Media, and in that we argued that there needs to be special consideration given to the frontline workers, well, all workers during this process, even almost like combat pay, because of PTSD and other things that are unique in what they're facing right now. And it sounds to me like you both have seen that firsthand.
Yeah, we did a fair amount of that early on, and are thinking of new and different ways that we can do things for the workforce. We need to, continue to look at our financial situation. We've just gotten our 3rd tranche of CARES Act funding in New Jersey and New York. We're rightfully so this time concentrated on. So, but we are looking at that as going to have to carry us for the next 2 years. We've kind of changed our approach from a fiscal year to a fiscal 2 year, with liquidity being the biggest thing that we want to focus on.
Yeah, we've gotten a lot of requests for specific hazard pay or combat pay, and we've said no. In Colorado, we've had Centura has been, I think, the caregiver in every single school shooting or Aurora,
Oh, I'll bet that's true.
yeah, so we think that's part of your work. But having said that, I talked about the things we've done. I think we will be doing more for our associates, but the whole hazard pay concept, we and the other systems in Colorado, most of the systems, I don't think you provided extra pay for this. It was just
a little bit of incentive for additional overtime in
Yeah.
high-risk areas.
Yeah.
Well, and to be clear, that my co-authors were Wayne Cassio and Andy Garman on the executive MBA faculty, and our argument was that they stepped up at a time that society needed them, and it's more a societal issue than it is an individual health system issue. They stepped up for all of us, and we all have a responsibility to bear with that. I've got another question then. Jabon Kutia, one of the faculty members, and I wrote an article too that suggested that the hardest, an op-ed, that the hardest issue here is to prepare. The best case scenario here is that we don't get any patients, but we've shut down all of our elective procedures, and society isn't as sick because we flattened the curve, but we financially devastated our systems. And it sounds like both of you are seeing that too. How do you prepare for getting through that financial devastation in the next 12, 24 months?
Well, we're right now, in fact, last night had a call with the Commissioner of Health in a small group about opening up elective surgeries, and she had just come off a call with Dr. Burks to get her opinion on it, and want to do it carefully. We're really worried, the scientists, the physicians, the experts are worried about a rebound in the fall, and we want to be prepared for that. So how do we continue to maintain over the capacity now that's lightening, but be ready for that? So it's a balancing act, I would say.
We reopened 2.5 weeks ago, so we let our physicians and clinicians drive how we were doing that. So we're taking some measures that probably have no science behind them, but it's trying to make people feel comfortable. So I'd say week 1 we were probably at 25% of normal. Week 2, we were probably at 50%. This week, we're at 75%. The emergency department volume, we're still at 60% of what we used to be. And I don't think that's coming back. The emergency departments traditionally have been full of, well, at least in our case, you have a little bit of a different case, commercial patients that probably didn't belong there. They could have had the virtual visit or primary care or urgent care.
Same with us.
And we're not seeing those coming back.
Is it?
So
we've seen that change right in front of our eyes.
Yeah. I don't think it. I don't think it's good. It's not, from my view today, it's not going to come back. So
yeah.
I think the unfortunate part we talked a little bit about is people delaying care that need it. So they've got cancer, they've got a heart problem where we've had patients pronounced at home, and the family said, well, they felt safer at home with the heart attack than they did on COVID.
Right.
So, there are some things that cannot be delayed, and so people need to seek care. And I think that's going to be, we have to be the source of the truth as a healthcare industry to say, as you said better than I can, it's safe to come. It's always been safe, and it's safe to come back.
Or do you have a
pretty big battle, I would say, and I think we're evening the playing field. About 3 weeks ago, the ambulatory surgery center industry, which has a very strong lobby in New Jersey, the physician-owned centers, were messaging that we should open first. Hospitals are full, and we're safe. We haven't seen a COVID patient, so we're clean and we're safe. So we took great exception to that, saying that hospitals have always been safe, like Peter said, and that we will be safe.
Yeah, we're finding here. Most of them don't have the PPE, aren't taking the precautions. Like we require temp checks for 10 days. You have to be COVID tested. We're finding about 0.1% of the people coming back are positive and asymptomatic. So we're taking extra precautions. I don't think everybody else is.
Yeah. Lauren, do you have another question come through?
We did. So we have another one, and this is specifically for Peter. The question is, when your clinicians came back from New Jersey, was there anything they noticed being done in New Jersey differently that you were able to adopt in Colorado and Kansas upon their return?
So the first group, the first 4 just came back today. So I can't really tell you what they said. The feedback I've gotten over the last couple weeks is life is a lot easier in Colorado.
I think that's something we'll both continue to work on too.
I think from a clinical end, the things they've seen your docs do and the rapid on the fly, and some of the advances you've made in treatment of the patients, we've probably not been as rapid, so they'll be bringing some of those back. But yeah, we're going to be spending a lot of time with them. I also think, well, the feedback I've gotten too is how we better engage nursing was really a takeaway from this, regardless of sending them there. But I think the nurses that got to see something different will have some nice insights on how do we better engage and support nursing in our organizations.
Great. Okay, I do have one other question that came in recently. So this is for both of our guests. We all have our fears during this pandemic. What are your greatest fears or what have been your greatest fears for your hospitals through all of this, and what has gotten you through it? What are your fears for the future related to COVID-19?
Biggest fear I had was what Peter mentioned, was protecting the staff. When we were, we all became, as one CEO said, I never knew I was going to become a professional PPE hunter. That was a lot of our time spent doing that to make sure. And then me at the Hospital Association trying to navigate 1 or 2 large systems going out and doing something that maybe didn't have science behind it, but they were going to PPE up all their employees, and the smaller hospitals complaining, well, they're doing that for competitive advantage and you need to mitigate that. So I spent a lot of time refereeing those things, and we were able to come up with a nice balance. I think in the future, Peter mentioned public health. That certainly in New Jersey has been underfunded, fragmented, and this pointed out the lack of resiliency. The other thing I should have mentioned that is a huge issue in New Jersey is the long-term care industry. I think it's close to 50% of the deaths now, and we've seen the resiliency of that segment of the industry not be there to get through this. So rebuilding those, I think, are key.
Yeah, I would echo the caregiver part. The one thing that I emphasized early on is I'm not going to have one of our people die, and I can't imagine you making those phone calls to the family, and that stuck with me throughout this, was not losing one of our caregivers because of COVID-19 and doing whatever we could to make sure that didn't happen. And that weighed on me, and I know when your first person passed away, that weighed on you. Yeah. And I can't imagine doing that. And we've done a good job, and we can't. We were talking earlier today on our daily briefing. Have to be vigilant. Can't let up. And that's, I think, going forward, I worry. We're not going to get to herd immunity until we have a vaccine. So how do we manage through this? How do we manage into the fall or winter where there's another surge? This is forever going to change our business and our business model. And so being able to adapt, for us, we found through this, we have way too much overhead and we can't support it. And how do you manage through that? And how do you in the ER, if it doesn't return, it's only at 60%. If you're an ER physician or an ER nurse, we're going to have to help you figure out how to retool, because the business isn't going to, patients aren't there for you anymore. So I think being able to stay ahead of how it's going to change our business and morph and transform in a way that brings everybody along on the journey.
That is wonderful. Well, we're getting close to the end, but I'm going to give each of you, I'd like to get some closing thoughts from each of you, but before we get to that point, I got to know about Bruce Springsteen.
All right, so go ahead. Can you go back to that slide? So Danilo Gallinari is an NBA player, played here in Denver, still lives here. He loves this place. He's a close friend of my cousin Tim, who lives in Littleton here, who's a great basketball coach here throughout his career. And he and Gallo are friends. So whenever Gallinari comes to New York, Madison Square Garden, we take a group. He's from Italy. I bring some Italian friends and doctors, and we have a group. And that's us after the game on March 4th with Gallo before he went off. I think that was one of the last. He went up and played in Boston Garden on Sunday, and that was when the NBA season shut down. During that time, right before that, New Jersey had their first COVID diagnosis, and our doctor, the connection is Dr. Jim Pruden, who's there on the top right, and in the middle leaving. He was our director of emergency preparedness, well known in New Jersey.
I worked with him too.
Worked with Jim, yeah. He's been at every 9/11 first responder for weeks, Katrina, Houston, you name it, he's led efforts, so he's well known. He runs emergency preparedness. The week before, he got our team together to prepare, and then on March 6th, became ill during his shift as an emergency room physician, got diagnosed and was positive, and was in the hospital for, I think 6 weeks, intubated twice.
That first touch and go, right?
He almost didn't make it twice. In fact, there were 2 rumors going around the state that he had passed. The governor texted me, "Did Dr. Pruden die?" And he said, "No, Facebook, Anyway, that week it began to leak out. It was disclosed appropriately, through the state that a physician, an emergency room physician, was hospitalized. That was really big news. The media was all over us. The New York media in particular. One of them got a source and said, "Well, we think we know who it is, and we're going to run this story." And we have great communication staff at the hospital, but also we have a tremendous crisis communication consultant that we use from time to time, Karen Kessler from Evergreen Partners. So she got involved, and she said, "You know what? Let's go public with this. Let's be forthright about it. Let's not try to hide. Let's not try to be picked away." So bottom left, I asked and was able to go to the governor's press conference that day. That's a lieutenant governor in the middle there, and disclose with Dr. Pruden's permission that he was that patient. And it was a public service message from Dr. Pruden to the residents of New Jersey that this could happen to anybody. So please follow the social distancing. And so he became a celebrity, and we a little bit alongside him during that journey. And then in the middle, that's his clap out in the lobby. The orderly to the left is me. I said I want the best one, so Shanna there on the right is our top transporter. So we took him out, great fanfare. And then the Jersey for Jersey concert, which Bruce Springsteen and others put together, John Bon Jovi, he was featured on that. He had a strong video message on that. So we took a situation that really, public relation wise, could have been pretty devastating for us, because Dr. Pruden exposed, as I mentioned, many leaders inadvertently. Didn't do anything wrong, we just didn't know at that time. When we did the contact tracing, it put out all those folks on quarantine. So it could have been a negative story, but we turned it into a positive with the help of some great communication experts.
Unbelievable. So who would have thought, as you were getting your Masters of Health Administration, to both of you, that one day there was a PR component to that, and you would find yourself at the governor's press conference. And now all of a sudden there you are, you've both got the governors calling you, and it's a good lesson for leaders. You got to do what you got to do. So, well, I want to thank you both for being with us today. This is a rare opportunity for any health administration program to have 2 luminaries like you involved in a webinar for our students and whoever else may join. You are great examples. We're thrilled that Kevin is an alum, and we're thrilled that Peter is involved with our program on an ongoing basis, and we'll continue to have that relationship going forward. So we'll thank you both very much for your time today. Thank you.
Thanks, Rulon.
Thank you, and thanks for coming on, leading the program. As a proud alum, I was really happy when I heard that announcement, Rulon.
Oh, you're very kind. Thanks, Kevin. I'm excited. Lauren, do you want to wrap this up? Tell us where we can follow up with this, and any about Q&A or anything. I'm not Q&A, but feedback.
Happy to. So we do have contact information on this slide here for anyone who would like to reach out to the Health Administration Organization, which has hosted this event. You can contact me and my email address is there. For any additional follow-up questions regarding the content today, you can reach out to Rulon directly at his email. I'll just echo thank you so much to Kevin and Peter for joining us today. Thank you, Rulon, for moderating, and thank you so much to all our attendees for joining us today. And with that, we're going to wrap up. Thanks, everyone, for your contribution, and have a great day.